So there's lots of different treatment options, though. There's watchful waiting, meaning you don't do anything but watch very carefully with serial MRI scans, and we defer treatment until, say, the tumor progresses in size or grade or symptomatically in some way. And that may be appropriate for some low-grade tumors, but not for anaplastic or high-grade tumors. You can have surgery with a caveat, and the caveat's important. If it's technically feasible with the goal of preservation of neurological function and an acceptable level of risk. You can have radiation therapy, you can have chemotherapy. The benefits of treatment, of course, should always outweigh the risks of treatment, and the risks of not treating also have to be considered in patients that you're considering watching. So surgery, if we talk about resection, what do you get from that? Well, you get a verification of the diagnosis, and you get more tissue from a resection than you do a small biopsy, so the grading may be more accurate. There's a relief of signs and symptoms if in some patients who have very large tumors where there's swelling and what we call mass effect. You get basically rid of those cells. That's what cytoreduction means. It means reducing the cell number. And in some patients, if you can do a large enough resection, that might improve outcome. It allows for a lower steroid dose. As many of you know, steroids are used to control swelling and edema, and they have their own set of side effects. So usually if you have less mass effect and a smaller tumor burden, in a sense, you can get away with either no steroids or a lower dose. We already talked about reducing sampling errors because you get a bigger piece of tissue. So it should be done if it's technically feasible with the goal of preservation of function. And as long as there's an acceptable level of risk. The extent of resection, if it's large enough, is an independent variable associated with a longer survival. So that means if you can get what we call a gross total resection, which is everything that we can see on the MRI scan is gone, or very close to it, like 80 to 90% of what we can see, or maybe slightly less than that, you will likely have an improved overall survival. But that shouldn't be done with the cost of, say, some serious neurological deficit happening. You know, if we hurt you more than we help you with the surgery, then it's not really necessarily a good thing. Some patients can even benefit from reoperation at the time of tumor recurrence.